Welcome to this final edition of the EAUTV at the 37th Annual EAU Congress, where we'll talk about liquid biomarkers. Today I'm joined by Dr. Isabel Heidegger from the Department of Urology at the University Hospital in Innsbruck. She's active in the field of urological oncology, focusing on prostate cancer research. And Kerstin Junker, who's chair of the Department of Clinical and Experimental Research at Saarland University, and also chair of the EAU section of urological research. Welcome both.
Thank you.
So this morning we had an interesting session on liquid biopsies. Recently we've seen a number of clinical trials being presented, and during the last sessions we learned more about the status of these different liquid biopsies analysis. So perhaps Isabel, you can start by share your view on the sessions on prostate cancer from your perspective.
So I definitely think that also in prostate cancer, liquid biopsies will have a great importance in the upcoming years. I definitely think that also in prostate cancer, liquid biopsies will have an important role in the upcoming years. I think it's important to differ between localized prostate cancer and metastatic prostate cancer. In localized prostate cancer, I think that genomic testing out of liquid biopsies is of highly importance because, as you all know, the EU guidelines suggest that all metastatic but also all high-risk prostate cancer who are under the age of 60 should be tested, and mostly this is currently done out of tissue. But I think in the upcoming years here, liquid biopsies would be definitely play a role. In addition, I would highlight the session on urinary biomarkers in localized prostate cancer from Professor Schalkin today. Here I think that we have good urinary biomarkers, but in my opinion, they are not ready to be alone as prediction value or even as to monitor patients under active surveillance. I think here we need definitely to combine it with, for example, PSA, MRI, or also digital examination. Concerning metastatic and especially metastatic castration-resistant prostate cancer, I think we have much more data and we are much more advanced. We have heard today several times that the ctDNA is predictive and also prognostic. There are really good studies on that. I think, again, here the most important in the near future would be genomic testing and genetic testing, as we have with the PARP inhibitors, the first biomarker-driven therapy in mCRPC. Generally, we have a bit of problem that we have overall nice concordance between ctDNA and tissue, but we know that only 60 to 80% of ctDNA is really measurable in patients, as this is highly correlating with the amount of tumor load. And especially, for example, androgen receptor mutations or alterations are not easy to detect if the amount of ctDNA is low.
What do you think about the contrast between plasma and urine samples in prostate cancer? Is it what is the highest value from your perspective?
In urine samples, you mean? Yeah, here I think the major issue for us clinicians is that most of the urinary biomarkers need a digital examination. And so, again, you need a doctor, again, you have to do some kind of invasive procedure. And I think the optimal goal would be to develop or detect a urine biomarker where you can skip the digital examination.
Yeah, thank you. So Kerstin, what about kidney cancer? We've had some interesting updates there as well. What's your personal highlights from this morning?
For me, it was very impressive that we have now data on cell-free or tumor DNA and plasma samples, because we learned that it's not so easy like in bladder cancer to detect this ctDNA, maybe because of a lower mutation load in this kind of tumors. But it seems that we can use it at least in the more progressive tumors and in later stages, which is, in my view, more important than for an early detection. And it was very nicely shown that there's a progress now also in kidney cancer. When we are talking about the role of these liquid biomarkers, in kidney cancer, I would say one point is that we can differentiate the tumor types, because in small renal masses we have the oncocytomas, which are benign, and so we are discussing that it's not necessary to perform a surgery in each patient, and we don't have very good tools to differentiate by, for example, by CT or MRI to say this is an oncocytoma or not. And so here it would be really nice to have good markers from plasma or urine to differentiate it. It might be that ctDNA is not the best because we don't know the mutations in oncocytomas until now, but there are also data on microRNAs, for example, and might be there are more data on this level in liquid biopsy in kidney cancer, where you can really distinguish between oncocytomas and, for example, clear cell carcinoma. And of course, we have to prove this in the future, but this is one point. The other one is, as in bladder cancer too, that we need discrimination in patients with localized disease to say, is there a risk of metastasis? And of course, we can use the ctDNA. I hope that we can use it, but as I know, there are not really good data at the moment. And again, it might be that other types of markers like the microRNAs, again, because they are most proof in kidney cancer, or methylation, DNA methylation can help here, and also maybe extracellular vesicles. And then we could better discriminate which patients need really an adjuvant therapy, which we have now for some months. So it's really now a clinical question what we have.
Yeah. So from your perspective and from the things we've heard at this meeting, which biomarkers do you think has the strongest potential right now in renal cell carcinoma?
I think we cannot answer it in general. So maybe for the differentiation between the tumor types, for example, microRNAs are more promising because there we have good data also from the tumor tissues. Yeah, and then when we are talking about also prediction of therapy, to select the best ones, we can use again really the ctDNA for that. So, and in the prognostic evaluation, yeah, maybe ctDNA is a good one if we are talking only about clear cell carcinomas, because we are knowing the mutations which are present there. But most data at the moment we have from the microRNAs really.
Yeah, thank you. So I think based on what you both are saying, I think we can conclude, and what we saw this morning also, that bladder cancer sort of leads the way when it comes to liquid biopsies. So we heard an update from the INVIGO-010 trial this morning also, where they had additional survival data on this cohort, and again they again showed, as they showed in the interim study earlier, that there is a survival benefit, overall survival benefit from the patients that are circulating tumor DNA positive that receive atezolizumab. And they again also show that the depletion of circulating tumor DNA during treatment is associated with overall survival. So I think that's very promising, and it's actually also independent of PD-L1 status and expression in these cases. So we also discussed these two trials that are ongoing in the adjuvant setting in bladder cancer, the INVIGO-011 trial and the TOMBOLET trial, where we are guiding treatment with atezolizumab to patients that are circulating tumor DNA positive. So I think it'll be interesting to see the results of these trials, and that may be a sort of a guideline changing if that comes out positive. So that'll be highly interesting to see in a couple of years when the data is mature in that way.
Yeah. But I think it's really important to show that we can use it, and we have to test it in these type of clinical trials. And this is a step what we are missing very often when in the urological tumor entities we have very good data, but the step to introduce in a clinical trial is often missing because we are missing the collaboration between both parts, and therefore it's a very good example now.
But I think it's also a matter of heterogeneity. So I think some of the markers we've been studying earlier have not been strong enough to actually enter a clinical trial. And I think we have some in the liquid biopsy setting where it is strong enough, and we can actually start to make clinical, we dare to make clinical decisions based on this. So, but that's important, and that's probably why the biomarkers have not been really introduced into the clinic in many settings. So it'll be interesting to look at this, but also to see if we can we improve the overall survival and quality of life of these patients and so on. So thank you to both of you for your expert commentaries here. This was our last EAUTV show this year. All shows can be viewed at the EAU22 website, the Euroweb, and YouTube. So we hope that you have enjoyed this Congress and look forward to seeing you next year in Milan.